Hello, everyone, and welcome to the course 577, Global Maternal Health, Cultural Perceptions and Policy Solutions. Now, I created this course for the Mel and Enid Zuckerman College of Public Health at the University of Arizona in 2022. And in this video, I would like to cover three topics. First of all, to introduce myself, who am I? Secondly, to look at the aims of the course. And thirdly, to clarify my expectations from you. So my name is Pricilla Magrath, and I'm a medical anthropologist, originally from the UK. And I've spent most of my career working on international development and global health programs around the world. Most recently, I've been working in Indonesia, but I've also worked in many other countries, including Ethiopia, Peru, and some other countries that feature in this course. So I came to the U of A to do my PhD and then continued here teaching. And my focus in my dissertation research, which I undertook in Indonesia, was on maternal health. And also, since I've been here at MESCOP, I've been working on maternal health locally for the Title V federal funded maternal and child health needs assessment that I've been working on with Arizona Department of Health Services since 2019. So moving on now to what is medical anthropology and what am I doing in the College of Public Health? Well, in a very, very shortened version, I would say that the goal of medical anthropology and anthropology more generally is to make sense of human behavior. This is socio-cultural anthropology, making sense of human behavior by really taking seriously the perspectives of the people we study and the context in which they are operating. So when I say the people we study, this could be in medical anthropology, it could be patients, it could be families, but it also could be health workers or policymakers. And in this course, we're going to cover the perspectives of all those different groups, people positioned differently in society. So my goal really with this course is to enrich our public health understandings of maternal health and maternal health policy by bringing in these anthropological perspectives, offering some new lenses. And as you may know, anthropology uses methodologies, very in-depth methodologies, long-term stay with communities, really trying to understand their perspective. And so my conviction is that if we add these perspectives to our public health repertoire or toolbox, then we can end up with more effective interventions that are really more collaborative and really based on an understanding of people's situation, because there's no point in asking people to do something that they can't do or they're not willing to do in their context. So this course will bring these contexts and perspectives from many different parts of the world. And I just really wanted to give a few examples of this, and this will maybe help understand how I've chosen the readings. I've chosen the readings very selectively, very carefully. As we know, there's a huge literature on this topic. And so I've tried to select articles and sometimes videos or podcasts that when I read them, it really changed my view or gave me an aha moment or shifted my understanding. And as a result, some of these articles are quite dense. They introduce new concepts. And so it's not easy. It'll take time to absorb these new approaches. And just to give an example, I mean, a question that is often asked in the context of maternal health is, why would a mother choose to give birth at home when there is skilled care available at a health facility that is accessible? Well, we could answer that in the context of the US or Europe, that particularly better off people, I think, are choosing home birth because they prefer it. But I think it's harder for us to understand that decision in context of very high maternal and infant mortality and morbidity. So we have several readings that address this and bring new perspectives. So in week 1, we have anthropologist Cameron Hay talking about this complex decision-making process in an Indonesian village where she worked, where she witnessed 2 infant deaths within a short space of time. And she really helps us to understand that agonizing decision-making process, the role of the so-called traditional birth attendant or lay midwife, and how much respect she earns in the community, how impossible it seems to actually go to a hospital when you're in a remote village, and also how things unfold in the moment. And it's very easy to look back and allocate blame, but you can't tell what's going to happen in the moment. They didn't know that those infants were going to die. So in week 2, I introduce a very different perspective from Vanessa Hildebrand, also in Indonesia. And in this case, and this is one of the aha moments, I think, she argues that a key reason that mothers don't go to the clinic is because they don't know how to repay this very valuable gift of assisting with the birth process. So in the village context, they know how to repay the traditional birth attendant, but they feel very embarrassed and intimidated at the idea of going to the clinic, because how can they possibly repay the nurse midwife for the work that she does? And I think this, as a real concern and something that really influences that decision, may come as a surprise to public health people, because we don't typically study gift giving and reciprocity and expectations of gift giving. That if you receive a gift, there is a responsibility and a matter of honor to return the gift. And if you can't return the gift, then you shouldn't. The idea is that you shouldn't receive the gift in the first place. And perhaps we can understand that if you went to an event and you were given a gift but didn't have any gift in return, it might be embarrassing, but we are maybe not used to transferring that experience to the context of giving birth in a facility. So these are just some examples, but I don't want you to get the impression we're really focusing on the families and the patients, because also in week 2, we have an article by Adrian Strong, who worked in a hospital in Tanzania. And the goal of this article is to present the perspective of nurses. So we're also covering healthcare providers here, perspectives from healthcare providers. And in this case, how can we understand the practice of some of these nurses of hitting and slapping mothers in the second stage of giving birth? And so I think Adrian Strong does a very good job of helping us to understand that from the nurse's perspective, this is the very best that they can do with the limited resources they have in order to avoid, in their view, to avoid a stillbirth. So in a way, it's sort of lesser of 2 evils. It's like, if I don't use these rather coercive methods, then I believe that the nurses believe that the risk of a stillbirth is going to be higher. So as public health practitioners, we really need to understand these perspectives, because there's no point in demanding things of those nurses. They're going to continue doing what they do if they believe that they're doing the right thing and the best thing in their situation. So we have to sort of shift the lens and ask, well, how can we reduce the risk of stillbirth for these nurses so they don't feel they have to use these coercive approaches? So in the later weeks, we shift again to the policymakers' perspectives. For example, in week 4, we look at how Claire Wendland helps us to understand how policymakers develop the maternal mortality ratio and some of the issues and complexities involved in that development. And in the week 5, we're looking at strategic work done by policymakers and aid workers in how they frame what they are doing in terms of statistics and evidence-based medicine, rather than, as they used to, framing it in terms of the right to health, because they recognize that in the current climate, it's the numbers that talk. You have to use the statistics. So that also brings in an interesting perspective, because it's not that they've given up the idea of the right to health, but it's a way that they feel they need to frame what they're doing in terms of whatever is the policy fashion of the time. So then we move on to the third module in this course, where we're looking at case studies of specific maternal health policies, and again, looking at them in the context of the whole health system and the complexities of, why gaps arise between the policy as intended and how it is implemented. So I hope that you'll enjoy these materials as much as I have enjoyed them, and I hope that you'll learn a lot from them. And really, just to clarify my expectations from you, as I've tried to emphasize, this is not skim reading. This is not reading you can leave to the last minute. Take your time and do an in-depth reading. Give yourself time to digest the concepts, read it again. I'm still rereading these articles and getting more out of them. And again, engage in the discussions. Each week, you're going to be posting to a discussion post. You won't see other people's discussions until you've posted your own. And then I really would encourage you to read each other's posts, and we can generate a real discussion and hopefully clarify any misunderstandings. And then, of course, you have your module assignments. Again, don't leave it to the last minute. They require quite a lot of reflection and quite a lot of work. And finally, if you have any concerns or ideas for this course, I will open a discussion post for that. But if you want to be more confidential, then please feel free to email me. So I'm very much looking forward to working with you during this 7.5-week course. And I hope you're also looking forward to working with me on this. Thank you very much for your attention.